Welcome to The Explainer. Today, we're pulling back the curtain on something often called a silent threat, a hidden danger lurking in our body's most critical pipeline. We are talking about thoracic aortic aneurysms.
But before we get into the weeds, let's just start with a basic question to get us all on the same page. Think about it for a second. What's the massive superhighway inside you that delivers life-giving blood to literally every corner of your body?
You got it, it's the aorta. This thing is an absolute marvel of biological engineering. It comes right off the top of your heart and acts as the main trunk line, the body's main pipeline, branching out to feed oxygen-rich blood everywhere from your brain all the way down to your toes.
But just like any high-pressure pipe, the wall of the aorta can get weak spots over time. And when a section in the chest, or the thorax, starts to weaken and bulge outward, expanding to at least 1.5 times its normal size, well, that's what we call a thoracic aortic aneurysm. The best way to picture it? Think of a dangerous bubble forming on the sidewall of a worn-out tire.
Now, these bulges can pop up in different spots along the aorta in your chest. About 40% of them happen in the ascending aorta. That's the part right after it leaves the heart. Another 35% are found a little further down in the descending part. And knowing the exact location, that's absolutely crucial for doctors when they're figuring out the risk and the best way to treat it. And it's not just location. The actual shape of the bulge matters a lot. Most of them are what we call fusiform. That's a pretty uniform, symmetrical swelling all the way around. But some are saccular, which look more like a little pouch or a blister sticking out from just one side. And these saccular ones, well, they're considered way more dangerous because they have a much, much higher risk of bursting.
So, after hearing about these dangerous, balloon-like bulges, the next question on your mind is probably, could this be me? Am I at risk? Well, let's dig into that, because understanding your personal risk is the very first step.
Okay, so there are a few key things that can really increase a person's risk. First off, age is a big one. It's mostly a disease we see in older adults, with the average age around 65. Then there's high blood pressure, especially if that bottom number, the diastolic pressure, is consistently over 100. That just puts constant, relentless stress on the aortic wall. And, no surprise, a history of smoking and COPD is a major, major factor, along with some specific genetic conditions like Marfan syndrome. And this is a big one. You absolutely cannot ignore your family tree here. Genetics play a huge role. In fact, get this. More than 20% of people with a thoracic aneurysm have a first-degree relative, we're talking a parent, a sibling, or a child, who also has one.
Now this is where it gets really real, because it's not just about getting an aneurysm, it's about the risk of it bursting, which is a catastrophic event. Look at this data. Having COPD increases the odds of a rupture by 3.6 times. That is huge. And for every single centimeter the aneurysm grows, the risk of rupture almost doubles. This is exactly why doctors watch these factors like a hawk.
So given all these risks, and the fact we're calling it a silent threat, you have to be wondering, how on earth does anyone ever find these things before it's too late?
And here it is. This is the core challenge, the very thing that makes this condition so incredibly dangerous. The vast, vast majority of people with a thoracic aortic aneurysm feel totally fine. They have absolutely no idea that there's a potential time bomb ticking away inside their chest.
So because there are hardly ever any symptoms, most of these diagnoses happen completely by accident. Seriously. A patient might go in for a chest x-ray because they have a cough that won't quit, or maybe they get a CT scan after a fender bender, and boom, the radiologist spots something. It's almost always an incidental finding.
The whole diagnostic journey usually follows a pretty clear path. It'll often start with just a small clue on a routine chest x-ray. From there, that suspicion leads to what we call the gold standard test, which is a detailed CT scan. That scan confirms it for sure and gives doctors the exact measurements they need. They can even use that data to create 3D models of the aorta to plan out every single step of a potential surgery.
So once that aneurysm is confirmed, it's measured, it's mapped out, the patient and their whole medical team arrive at a major crossroads, one of the most critical decisions in all of medicine.
Yeah, it really all boils down to this high-stakes balancing act. On one side of the scale, you've got the terrifying risk of the aneurysm rupturing if you just leave it alone. But on the other side, you've got the risks that come with a major medical intervention, whether it's open-heart surgery or something less invasive. So, what's the tipping point? When do you pull the trigger?
Now, doctors look at a lot of things, right?
the patient's age, their overall health, the shape of the aneurysm we talked about. But when it comes right down to it, the decision to step in is overwhelmingly driven by one single number. Its diameter. Size is the best predictor we have for rupture. For most of these common degenerative aneurysms, this is kind of the magic number, 5.5 centimeters. At this size, the general consensus is that the yearly risk of it rupturing starts to become greater than the risks of going in and fixing it preventatively.
But, of course, medicine is never quite that simple. That number can shift. For really complex aneurysms that cover a larger area, or in patients who have those genetic conditions we mentioned, like Marfan syndrome, surgeons might actually wait until it reaches 6.0 centimeters before they recommend an intervention.
So this all leads to two very different game plans. For the smaller aneurysms, it's a strategy called watchful waiting, or medical therapy. The goal there is simple: slow down its growth. That means super strict blood pressure control, maybe some statins, and absolutely quitting smoking. But once an aneurysm hits that critical size, the goal changes completely. It's now about preventing rupture through intervention, which could mean open surgery or using a less invasive stent to reinforce the wall from the inside.
So what's the bottom line here? The big takeaway is that while a thoracic aortic aneurysm is, without a doubt, a very serious condition, it is often manageable. Knowledge is everything. Understanding your family history, aggressively managing your risk factors like blood pressure, and just being aware of these treatment guidelines, that's what can turn this silent threat into a condition you can handle proactively. And that really leaves us with the big, final question, doesn't it? As our treatments get better and safer every year, the real frontier, the biggest challenge facing the medical community today, isn't just about how to fix these things. It's how do we find them in the first place, in the millions of people who have no idea they're even at risk. Answering that question, that's what will truly save lives in the future.